Continuing on in Chapter 9, maternal blood assays. There are several different maternal blood assays that can be used to look for potential complications to the fetus. MSAFP is the maternal serum alpha-fetoprotein. This test screens for neural tube defects. There's also the multiple marker screens, which evaluates for Down syndrome, which is trisomy 21. It looks for the biochemical markers of PAPPA and human chorionic gonadotropin. The triple marker screen evaluates for trisomy 21 and also trisomy 18. It uses the MSAFP, unconjugated esterol, and human chorionic gonadotropin. The quad screen, which is one that's pretty typically used more than anything, evaluates for trisomy 21 and includes the things from the triple marker screen, but also uses the addition of inhibin A. You need to review non-stress tests and contraction stress tests. These were presented in Unit 3. Please go back and review the previous YouTube videos. Just as a brief overview, NSTs, you should see accelerations, which is a 15 by 15 increase in heart rate over the baseline, which should be between 110 and 160. And so we should see 2 of those accelerations in 20 minutes. A contraction stress test, you evaluate the fetal heart rate in regards to it in conjunction with spontaneous contractions, nipple stimulation, or the use of oxytocin. Please go back and review how to interpret NSTs and contraction stress tests. Objective 42 says list predisposing factors associated with preterm labor and birth. Preterm labor is defined as cervical changes and uterine contractions occurring between 20 weeks gestation and 37 weeks gestation. A preterm birth is any birth that occurs before the completion of the end of the 37th week of pregnancy. Late preterm births account for 75% of all preterm births occurring between 34 and 36 weeks gestation, and very preterm births are babies born before 32 weeks gestation. Those are just basically definitions. Risk factors and common causes of preterm birth. There are many risk factors for preterm births, including a history of a preterm birth, current multifetal pregnancy, cervical and uterine abnormalities, bleeding after the first trimester of pregnancy, low or high maternal body mass index. There are many other risk factors associated with preterm birth. Those are just the major ones. However, infection is the only factor that has definitely shown to cause preterm labor, and that's typically some sort of infection in the vaginal area. There are some screening tests for preterm labor. Fetal fibronectin, FFN, is one of the screening tests that can be used to identify preterm labor. What fetal fibronectin is the glue-like protein that holds the developing baby in the womb. Fetal fibronectin can be performed between 22 weeks gestation and 34 weeks gestation. Before 22 weeks and after 34 weeks, fetal fibronectin is normally found in the cervical area. During that time, it is not. The thing with fetal fibronectin is this swab must be performed first on the speculum exam before any other vaginal exams or any vaginal swabs for any cultures are taken. So nothing must be in the vagina prior to collecting a fetal fibronectin. If the patient has had sex in 24 hours, again, it may alter the results of the fetal fibronectin test. A positive fetal fibronectin means there's a chance that she may deliver within the next 2 weeks. A negative fetal fibronectin says that she will not deliver within the next 2 weeks. And that way the physicians can determine their modality of care based on the results of the fetal fibronectin. Cervical length, again, the normal cervix is between 4 to 5 centimeters long. So if the cervical length is greater than 3 centimeters, it's very unlikely that the patient will give birth to a preterm baby, even if there's other signs and symptoms of preterm labor. Cervical length can be obtained by ultrasound. Objective 43 says discuss the therapeutic management of preterm labor. Prevention of preterm labor is pretty much the biggest part. This is on page 488 in your book, which is Nursing Care Management of Preterm Labor. We need to educate the patient on the early signs and symptoms of preterm labor. And this would be things like abdominal cramping, being on their feet, not feeling well, all that kind of stuff would be potential signs and symptoms of preterm labor. How to prevent preterm labor is also to increase fluids during pregnancy, ensuring that they're getting their 3 liters of water to drink per day. Proper nutrition is very important. Good nutrition, exercise, and stress management will help prevent preterm labor. And then also good prenatal care will help prevent preterm labor as well. Another therapeutic management of preterm labor is early recognition and diagnosis. Again, preterm labor is defined as labor between the gestational age between 20 weeks and 37 weeks gestation, where there is uterine activity, meaning the patient is having contractions. Also, there's progressive cervical change, which means the effacement of the cervix is greater than 80%, or there's a dilation greater than 2 centimeters of the cervix. One of the things we can help with preterm labor is do some lifestyle modifications, and that would be limit engagement of sexual activity, which is known as pelvic rest, meaning nothing in the pelvis at all, not have going for in a car for long distances, not carrying any heavy loads, not standing for long periods of time, no heavy housework, climbing stairs, or hard physical work. And again, if somebody is having some signs and symptoms of preterm labor, they should increase their non-carbonated, non-caffeinated fluid intake. Another therapeutic management for preterm labor is bed rest. It is commonly used with preterm labor. There is very limited research to support the efficiency of the bed rest on preterm labor, and bed rest can lead to potential complications such as venous thromboembolisms, which is DVT formation, muscle atrophy in the mom, and decreased physical and mental stimulation from the isolation of being on bed rest. With bed rest, there are some things that can happen with home care. With home care itself, the patient can have a nurse come in and monitor for uterine activity. She may also have some telemedicine where she can hook herself up to contractions, and those are recorded over the phone, and the physician can see that. There can also be use of medications for suppression of uterine activity. We use tocolytics for that, including terbutaline, which is known as breathing, magnesium sulfate, indomethacin, which is Indocin, and nifedipine, which is Procardia. Again, there are side effects to each one of these medications. Terbutaline is actually a medication for the respiratory system. It will cause shakiness and jitteriness in the patient. Magnesium sulfate is a CNS depressant, so we need to watch for respiratory rate with that. Indomethacin is an NSAID. It can only be used for 48 hours because we don't want to constrict the ductus arteriosus. And Procardia is a calcium channel blocker, so it will drop the mom's blood pressure because that is what it's typically used for in normal patients on Procardia. Also, there's a promotion of fetal lung maturity if the baby is probably going to be delivered before 36 weeks, and that's the use of antenatal glucocorticoids such as betamethasone. And that is on a medication guide in chapter 19 on page 496. Betamethasone or dexamethasone can be used to accelerate fetal lung maturity. This is the one that actually accelerates fetal lung maturity, and it can be given between the gestation weeks of 24 and 34 weeks gestation to speed up the surfactant production. For the tocolytics, going back to the suppression of uterine activity, if you refer to box 19.6, there's contraindications to tocolysis, and in 19.7 there's nursing care for women receiving tocolytic therapy. There's also a medication guide in chapter 19 that includes breathing and magnesium sulfate, Procardia, and indomethacin. It's important to know, again, the adverse reactions and the nursing considerations with using any of these medications so you can readily inform the patient as to why these medications are going to be used and the side effects of these medications. Uterine relaxants, again, tocolytics. It's Not My Time, indomethacin, nifedipine, magnesium sulfate, and terbutaline. Preterm birth, if the cervical dilation is greater than 4 centimeters, there's going to be an inevitable preterm delivery. The cervix does not have to be dilated to 10 centimeters in order to deliver a preterm baby. They can deliver through a partially dilated cervix. If there's going to be a preterm delivery, especially in this area, a tertiary facility with the appropriate neonatal nursery should be available, and if we can transfer mom during labor, early labor, it's better for both her and the baby to be together in the same facility. The first dose of antenatal glucocorticoids should be given prior to that transfer. If it's unable to transfer because she is too far along in labor, then especially in this area, the neonatal flight team needs to come and be readily available after the delivery of the baby. Tertiary care centers can be far from home, leading to a negative psychosocial impact. We try to keep mom and baby together if all possible. Nursing management, you need to prepare for preterm birth and delivery, have readily available equipment and resuscitation supplies, and remember that this baby may deliver through a partially dilated cervix. And just have everything ready to go because you never know when that's going to happen. Objective 44 says develop nursing diagnoses and interventions for clients experiencing obstetrical procedures. Again, you need to go into your NANA book and look up the following procedures and diagnoses and review the interventions for the nursing diagnoses for each one of these procedures, including an amniocentesis, stress, RH factor incompatibility, anxiety, and deficient knowledge. Remember, your interventions is what you do as a nurse. Nurses educate. You need to be able to educate the patient on what is going on. You are the patient advocate. You need to know your interventions so that you can properly educate your patient.